morning, everybody.
First of all, I thank
Professor Manoj for inviting me for this CME. Also thank Professor Nikhil for his able organization with his team. And I think senior faculties are there and my dear students. Now topic is demonstration of the
thyroid examination. I'm not going to discuss any debate or
controversies here. My job is to demonstrate. So initial 15 minutes I'll go through the slides quickly, and another 15 minutes I'll go through the video, how to demonstrate. And yesterday we had a lengthy discussion of thyroid examination, and two cases had and had a panel discussion. It's just a repetition. I'm not going to discuss about history. All of you know, just to go through the slides. Important thing is it can be different way like this. What is important is male thyroid is a high risk always. Remember, thyroid swelling is uncommon in males, but when it happens, you would suspect malignancy. It's a basic thing. Male sex itself is a high risk category, and any thyroid can be malignant unless proved otherwise.
Neither the duration, nor the consistency, nor the size.
There's a dictum which we were taught long ago.
Still holds good in many situations. And you know that
thyroid is the only endocrine gland which is properly accessible clinically, and that can be involved in all age groups. Only gland where malignant tumors are mostly non-functioning. Unlike other endocrine glands, malignant tumors are commonly functioning. This is the place where malignancy, thyroid malignancy is uncommon to have a functioning status. So chief compliance is very important. All these 2 days you had been have discussion. There's a lacunae in writing case sheet and presenting chief complaint is very important. This is the order. First presentation is swelling with certain exceptions. In toxic thyroid, sometimes they present with the toxic features, then swelling. Otherwise, usually swelling, pain, hoarseness of voice, weight loss. We had a debate on when it happens in toxic thyroid, weight loss, increased appetite, weight loss and loss of appetite in malignancy. Say that it's a withdrawal involvement, weakness, palpitation, tremor. All these things are important. This chart, I'm just putting chart.
I'm not going to debate because I'm mainly demonstrating the local examination.
Swelling is the important history. Pressure symptoms is the second important history. Functional status is the third important history. Family history is very important. Today I've told 3-generation detailed family history is a must. For that matter, all long case, when you write a case sheet, the siblings, parents, their siblings, children, then relevant history with a family tree. So that much your case sheet should contain that much. That's important thing. Again, menstrual history is important. Drug intake is important, which may cause toxicity, which patient may be taking antithyroid drugs and so on. So that's also important. And examination again here, most important is eye signs. Every eye signs are not relevant. There are around 20-25 eye signs at your level, whatever I have mentioned. These eye signs, if you remember and practice, that is more than sufficient at the postgraduate level. If you are asked in the exam, you tell, I have read it, I have forgotten. It is impossible to remember all those eyes. They are of academic interest. They are also sometimes important. The NEET exam, because NEET exam sometimes
glory questions will be asked, may not be able to recollect.
Such a situation, you may have to by heart such things. Otherwise, it is not necessary to remember. You can always refer such things for your academic interest. Only these eye signs you have to remember. Telvax, Wangraves, whatever I have mentioned. And local exam, this is what I am interested today. So again, local examination, swelling is all like any other swelling, you know, that shape, size,
margin, location, anatomical relation, skin dilatation. I'm not going to detail that, you know that already.
The most important thing is the movement with the deglutition. It is the most important inspection which you have to give glass of water, then ask the patient to swallow, then find out whether it's moving with the deglutition or not. And pressure effects, again, dilated veins, all those things I've discussed. Toxic thyroid, malignancy, if there's retrocessional extension, it may be there. Pizzol's method, it's like this. I'm going to show that, especially in the short neck, obese patient, large thyroid. And I'm not going to detail, you can read it, this WHO grading. Palpation is again same like any swelling, rise of temperature, tenderness, shape, all those things. Now measurement is important, people get confused. Thyroid is a single gland anatomically, it's a single gland functionally, it is considered as a single gland surgically also, remember. So when you measure from one thermostat to entire gland, you have to measure. It is not right lobe separately, left lobe separately. Eventually, if you want to segregate, 14 centimeter length and 10 centimeter vertically or derivatives, eventually tell right lobe is it is this, left lobe is like this, isthmus is like this, and segregate eventually, not to begin with, because it's a single gland. And circumference is often important, especially when yesterday you had a discussion, many current guidelines, which many times in our country may not be able to follow. If you are following, if it is so, you have to do circumference, measure it and keep it in the sheet, OP sheet. And after 1 month or two, again measure the circumference. If it is increasing, it is relevant. You have to think whether you are going to do surgery or not. Next thing is plane of the swelling. Contract the sternocleidomastoid is the most important thing, whether it is deep to sternocleidomastoid muscle, all the muscle or not. Key muscle in the neck is sternocleidomastoid muscle. Any swelling in the neck, lymph node or anything, any swelling in the neck, when it is enlarged, you have to always interpret in relation to sternocleidomastoid. It's the key muscle in any swelling in the neck. So without contracting this muscle and examining the neck swelling, your examination is totally incomplete. You had pulsation, mobility, fixity. Thyroid is independent. There is no independent mobility for thyroid. It moves horizontally along with the trachea. There is no vertical mobility. It moves with the filtration. That's the only thing. And thrill, I have told, superior pole anteriorly, carotid pulsation at the level of thyroid cartilage on the inner aspect of the sternocleidomastoid muscle. There was a controversial statement yesterday about the Chesanak tubercle. Now remember, it is not the landmark. It is where it is located. That's what is mentioned. Definitely question asked. Your answer should be well accepted. Don't be panic. Now look at the femoral artery in the peripheral artery disease. When you palpate, femoral artery is palpated 1.25 centimeter below the mid-inguinal point. But femoral artery, on which bone you will palpate? Over the neck of the femur. So neck of the femur, you can't point, you can't mark it out. It's not surface marking. Surface marking is different. All of you know that any artery should be palpated over a bony surface. So this is what exactly it meant. So if you express differently. So it is palpated over the Chesanak tubercle. You are not palpating the Chesanak tubercle and then search for the parotid. There is the academic interest. Your palpation surface marking related to the thyroid cartilage. So if you say Chesanak tubercle, is not wrong. Remember, other exams are already told: oral cavity, percussion, sternal tenderness, and mainly for the retrosternal goiter. Systemic exams are again important. Abdomen specify. Spleen is important. Thyroid, toxic thyroid, Hashimoto thyroid. Liver is mainly in the malignancy, and so on. You should have specific reason why you want to examine. Skull is very, very important in follicular carcinoma of thyroid. Oral cavity, sometimes you'll get it like this: lingual thyroid. Skull, mainly frontal bone, you have to examine. And cardiovascular system and respiratory system also very relevant, because in toxicity, CVS is very important. And second is, you can see this second issue, there is a thyroid scar is there, and how exactly, this is the very common site. This area is very common. So always palpate skull, especially frontal region, where follicular carcinoma thyroid secondaries can occur. You know, that's a localized, warm, pulsatile, soft secondaries. All bone secondaries, when primaries elsewhere in the body, are not pulsatile. They are hard, except follicular carcinoma thyroid, because there are two reasons: both outer tables and inner tables are disrupted, and many times when these malignancies contain colloid, because there are the follicular tissues. That's why this is soft it is. So brain pulsation is transmitted across the disrupted two tables of the skull. So that's why you get the pulsation. It's not just vascular; it is also very important. Vascular angiogenesis factors are there. Additionally, this is also important. Why it is vascular and pulsatile, the secondaries in the skull. And diagnosis, again, don't write like an impression. I have seen many PGs are telling, my impression is, you are not bothered about your impression. You are bothered about the clinical diagnosis. You are supposed to tell what should be told. The scientific word is clinical diagnosis, not impression. My impression, nothing is there. Don't write impression. Write clinical diagnosis. This is what you are supposed to write. So write like this diagnosis, and how you will manage. I'm not going to detail it, but make a note in a long case in the exam. Investigation, briefly mention it, 1, 2, 3, 4, so that You can always see that, sir, I have written. So it increases your confidence when you present. So quadruple assessment is a discussed, unlike triple assessment for breast. Treatment, again, briefly mention your treatment in the case sheet. That's also important. Again, go back to the inspection. Inspection or inspect all around. That's important. All those things are not said, surface, swelling, additionally. The most important thing is movement with the deglutition. Thyroid moves upwards with the deglutition because there is a lot of controversy about the varus ligament at your level, not necessary. I have done the enough study about that. Pretracheal fascia anteriorly is a thin. This diagram shows very clearly. Posteriorly, it is thick. Posteriorly, it is upper part is thick, that is condensed. So condensed thick upper part pretracheal fascia, which is attached to the cricoid cartilage, which makes the thyroid moves upward the deglutition. Now, why it moves hyoid bone, cricoid bone, inferior constrictor during deglutition? All those things are the additional concept behind it, which is not necessary. At your, if they ask you, just blindly tell, I don't know. But upper posterior part of the pretracheal fascia, which is condensed and which is attached to the cricoid cartilage, makes the cricoid to move upward during deglutition because inferior constrictor moves upward. That's how exactly you have to give the answer. This is the most important thing. Say it is thyroid. All these different possibilities can happen. So all these things has to be known. The small nodule, pseudonodal thyroid, colloid goiter, there's a butterfly-shaped thyroid, multinodular goiter, malignancy in the male patient, toxic thyroid patient is there, skin involvement. All those things has to be properly inspected in these patients.
The Pigeonhose method, the short neck, how exactly you do it, or the occipital tools like this.
The correct method, then inspect. Now, Pigeonhose method is used both for inspection and
palpation, remember. And skin fixity, deeper plane is mainly for palpation, remember. Skin is involved here. And same thing, palpation.
Where you'll put your, always initially start palpation from behind. Ask the patient to sit in a comfortable stool, not in chair, so that you can move around like that, around the patient. And go behind, ask the patient flex and put your thumb over the occiput. That is how exactly it is shown there, over the occiput. And later, of course, front, you can feel different nodules, surface, whatever you want to feel. Yesterday we have discussed that. This is the Kreil's method that you do from front with the thumb or pulp of the finger. Feel for nodules, not only feeling for nodules, appreciate its different features, how consistency, everything you feel, how many nodules are there, everything is by. So measurement again, I said vertical first. Any swelling, you know that vertical in centimeter, not in inches. Horizontal later. If it is longitudinal, tell longitudinal and transverse. And then horizontal from one to other. Then later you can segregate and write circumference when you are doing a follow-up. And plane of the swelling already told, contract against resistance like this or others like this. And skin pinching also important, if skin is involved or not. And again, palpation of trachea like this 3-finger test, all of you know. Trail sign is, trail sign. Opposite sternum becomes more prominent with the loss of hollowness. Hollowness there, opposite side, there is the trail sign, all of you know. And thyroid thrill is felt rather anterior, in the anterior aspect. Carotid is posterior, remember. See that you can see in the diagram, thrill is felt in more anterior than the carotid is posterior. So your finger placement is important when you feel thrill and carotid pulsation. Lower body is very, very crucial, especially during swallowing. That makes a lot of difference whether there's a extension or not. Do not forget lower border in all thyroid swelling. And Pemberton sign, if lower border is not clear, then there is a controversy about whether to do or not. There are two tests, there are controversy, Cockers test and Pemberton sign. But I am just demonstrating, so I'm not going to debate about that. There's a arm should touch the ear, that is important. And this is how exactly Pemberton sign, because you can see that dilated veins are there, arms are up. And Cockers test, compress both lateral lobes equally, posterolaterally, then they develop stridor. Remember, it is a sign of compression. This is not a sign of infiltration. Sign of infiltration is stridor at rest. That is the point you have to remember. So benign, long-standing, large multimotor can also cause weakening of the tracheal cartilage. You know that tracheal cartilage anteriorly is a C-shaped. Posteriorly, there is no cartilage, there is trachealis muscle. So when it collapses, over the trachealis muscle and they develop stridor. But the large thyroid itself hangs forward, falls forward and keeps the thyroid patent, trachea patent. But when you do surgery, after removal of thyroid, there is no support for the cartilage, so it collapses and causes the tracheomalacia. Let's say we need tracheostomy for 3 weeks. By then, tracheal rings regain their strength and you can close the tracheostomy. It is not permanent tracheostomy. 3 weeks duration, remember that. And Leahy's method again important, especially in the solitary nodule thyroid. Push one opposite lateral lobe towards the other side. Trachea rotates like this. When trachea rotates like this, and lateral posterior lobe becomes lateral. It's a rotation which any tubular structure, when you press, it's the physics, press it rotates. That's what when you press the trachea rotates, that posterior becomes posterior lateral, you can feel the nodule. Mainly very specific for solitary nodules. So if you feel any nodules in the posterior lobe, then your initial thinking of solitary nodule becomes multinodular goiter. So you should have a Leahy's method and say there are no nodules felt during Leahy's method. Then only you can give a clinical diagnosis of solitary nodule thyroid. Of course, current definition, guideline wise, ultrasound also comes under the clinical method. In such a situation, your definition will have the different entity as such. So mobility of thyroid, I said it moves only horizontally along with the trachea. There is no independent mobility for trachea. Cervical lymph node examination is very, very important. Again, we had a debate yesterday. Lymph node examination is standardized in the neck, level 1, 2, 3, 4, 5. You tell those things, that is sufficient. Anything else is standardized, it will be well accepted. But to make it, always remember, when the neck lymph node, when you palpate, don't palpate both sides together. Palpate one side first, then opposite side. Never put both hands together. That is not the proper clinical method examination. One side first, 1A, 1B, 2, 3, 4, 5. Then on the opposite side, never put both hands together in the both sides. It is not the right method, one after other, remember. And check the pulse and blood pressure. This is important because collapsing pulse may be there. And toxic signs, hand tremor is quite common. Eye signs, Van Grief sign already discussed yesterday. Put your finger, run your, whether patient eyelid keeps pace with the eyeball. If you're not keeping pace with the eyeball, that means positive. And Mobius sign is like this, convergence. It's very important. If it is negative, if it is positive, then probably patient is going for malignant exophthalmos or ophthalmoplegia. Inferior retina and inferior oblique may be involved. And Naff-Ziger sign, whether exophthalmos is there or not. And additionally, Geoffroy sign. Important thing is not like this. Flex the neck, then ask the patient to see the eyebrow like this. That's important. See the wrinkling. You have to flex and do it. If you don't do that, that is wrong. Flex and ask the patient right. These are the only 4 tests you are supposed to do in a toxic thyroid. Any additional test of academic interest, it is difficult to remember and difficult to execute in a given patient, remember. And this is the pretibial mixed edema. Again, in a toxic thyroid, it's very important. And percussion, sternum, the direct method is a usual thing, but only thing, direct method is painful. Sometimes we use indirect method also. Auscultation with the bell of the stethoscope, the breathe in the superior pole. All of you we have discussed these things yesterday. And remember all these things. I have not to go into detail these things. Functional status, compression, neck node, tracheal deviation, features malignancy, retrocerebral extension, cardiac, abdominal respiratory system, bony secondaries. Kreil's method, Kreil's grading for the toxic thyroid, 90, 110 above, like that. And all those modalities you have to just remember. This is the thing you have to always remember. And again, important thing is examine thyroid all around. That's important. Go around. That's why I ask the patient to sit in a stool and make adequate space all around the patient. So go around the exam. That's important. And this is a thyroid after specimen. After thyroidectomy, specimen looks larger than actual. Because yesterday it was discussed, it goes posteriorly. So what you see actually may not be same what you get after surgery. And this is the Emil Theodor Cocker's surgeon 100 years back, got the first surgeon to get Nobel Prize in 1913. Did extensive work on thyroid surgery. He is from Switzerland, Bern. And the Cocker's, there are so many Cockers in Cocker's test, Cocker's instrument, Cocker's vein, Cocker's method of reducing the shoulder joint. There are so many things are there. I'm not going to detail. You can always read the book. Just see the video. See that inspection all around. Inspect, go around, see everywhere. Margin, extend, relation to thyroid. Lower border inspection, whether there are neck nodes are there or not. This is most important thing. Give a cup of water, ask the patient to swallow, see whether it moves with the regurgitation or not. Without doing this one, you can't say it is thyroid. That's the most relevant test you have to do. Thumb should be placed behind, over the occiput. That's what I already shown the photo. And then fingers will be in the front with the flexion. All these things are discussed yesterday. Measurements from one side to other side fully. You have to see fully. You have to measure individually. If you want individual lateral lobes, if you want to measure later, you can mention. It's a gland is the entire entity. So that's what exactly. Circumference, when you do a follow-up, neck node exam, this is the Kreil's method. Lower border is very important. Ask the patient to swallow. Usually you put your left hand over the patient head so that patient won't move, and patient gets stabilized, and patient also psychologically feel that I am comfortable. So that's why this left hand, whenever possible, put over the head of the patient. And this is the contraction sternocleidomastoid muscle, either on the opposite side or like this, if you want to do both sides. This is a Pizzolo's method on inspection. On palpation also sometimes you can use. Leahy's method, mainly in the solitary nodule, create a rotation of the trachea, then feel posterior becomes posterior lateral, feel over the lateral aspect for any additional nodules. So this is the trachea palpation on the 3-finger test, whether deviated, palpable, not palpable, deviated, central, all those interpretations you have to do. That is Cocker's test, posterior medially press, compress, whether they develop slider or not. There's a controversy whether you should do it or not. I'm not going to discuss all these controversies. My job is just to demonstrate. Pemberton sign again, arm should touch the ear. That's the most important thing. Carotid pulsation over the thyroid cartilage medial to the sternocleidomastoid muscle. Both sides don't palpate together in the exam when you demonstrate. It is not accepted. Trill in front actually. Carotid is larger posterior. Trill in front actually. Neck lymph node examination. 1A, 1B, 2, like that, orderly. That's very well accepted. Nobody will question if you say that these levels are examined like this. But one side first, then on the opposite side. Percussion, usually like this. Some old books, clinical books, I mentioned that you can use fleximeter and palpatory fingers. Indirect method it is called as, because it is bone to bone. For your percussing bone over a bone, your inference may not be adequate, but it's painless. Direct is always painful. Auscultation over the superior pole. Skull and spine is very important. I already told why it is so. When the spine, when you examine, rotation takes priority. Rotation should be checked always in a sitting position. Otherwise, it will become a composite movement. You have to fix the pelvic girdle. Respiratory system, cardiac systems are definitely very relevant in thyroid examination. Abdomen examination, liver and spleen. Spleen for already given the reason, Hashimoto's, Graves. Liver for malignancy. Ankle jerk, knee jerk, again toxic thyroid.
Pre-tibial mixed edema, I put the other exam at 10 actually. Pre-tibial mixed edema you have to look for, and especially in the primary toxic goiter. And pulse, collapsing pulse again, that's very important in toxic thyroid. Tremor, hand and tongue. It's extended like this. Correct method, tongue within. If tongue is outside, contracts, I may not be able to get it. This is the wrong method. BP should be checked always in thyroid examination. Eye signs, one reef like this. Check the eyelid movement that passes with the eyeball. Usually around 3 to 3 feet distance. This is the Mobius sign like this, convergence. Inferior rectus and inferior oblique, remember. This is the first thing get infiltrated with the lymphocytes. Later all muscles becomes muscle, we won't be able to get any movements. Knife zygers and from behind. Don't flex your head. It should be like this, and ask the patient extend like this. Then you should be able to see the protruded eyeball. This is the thyroid, large thyroid malignant which we operated 2 weeks back. Right, IJV we had to sacrifice. We have done a tracheostomy in this patient. So again, large thyroid also many times may not be able to get a proper movement with the regulation, and many findings may not be able to elicit. But careful observation is required in such patient, and that is all those movements are as if it is mobile. It is apparent mobility. It moves everything with the sternomastoid muscle and other things. It is not the independent mobility. You feel like we are eliciting the mobility. Actually, it is not so. This patient could not, shoulder joint problem was there. This is just a male patient. Just to go through the video. Now, important thing is proper history and orderly examination. Systemic exams also very essential. Neck node, systemic exams, lower border, sternomastoid relation, muscle relation, trill, bruit, all those things are important. And some books it is mentioned that you put that tongue up and see whether it is dysphagia. It's very difficult to contract dysphagia that easily. So there is no proper clinical method to contract the dysphagia, remember.
So this is examination. Again, remember,
clinical method is the
first level pillar for learning surgery. Clinical methods, it gives how to examine a patient, how to correlate, how to analyze, how to
have imagination about the patient and how to have application towards the patient. So
examination, analysis, correlation. We had two discussions, just three case discussion. It's just thinking, it's the analysis, it's the correlation. So that is, it teaches you to take the decision.
So decision making is the most important thing in surgical side. It is not the image.
It is the imagination which is most important in surgery. You will do image, you will do everything, but finally you will take a call by whether on the clinical instinct in that particular patient. That's why clinical method is still very important, standard, it is essential. It provokes your thinking process. It allows you to think, analyze what exactly it is. So it is a learning process. Surgery is the principle. Surgery is not just cutting, remember. It is principle. It is an art. It is a specified art, remember. So this, it is not, you are artists, you are not artisans. So you need to know the principle when you do all these procedures. So that's why clinical surgery is very, very important. So again, remember, male patient is a high risk.
So need to have a additional thinking, right, whether it's malignant or not. And every thyroid can be malignant unless proved otherwise at that point.
Then currently, of course, I got better quadruple, of course, quadruple assessment you have to tell in the exam. FNAC and ultrasound. First thing is ultrasound. Everything is ultrasound. Different hypoechoic, anechoic, all those things. Echogenicity, composition, calcifications, margin, tall or wider. All those things are discussed actually. Taller is dangerous than wider. Everything is discussed. Echogenicity, other
echogenic foci, type of calcification,
rim or multiple calcification. All those things are discussed. So sonology is very, very essential in evaluating thyroid. It's the point which always you have to remember. Again, percussion is the direct method. That is what I said. Some people do indirect method, but it's got its own limitations. Auscultation, again, in the superior pole. Skull examination is very, very important. Don't forget. Spine examination also, mainly skull and spine. I hope you understood, students, this basic thing, which is very, very essential in the thyroid, very compact area, very common long case kept in the exam, and all those discussions which we had yesterday is definitely very, very relevant, very, very useful. This is my website. I got website, SRB Surgical Insight. Daily brief 5 to 10 minute lectures are there. It's a free actually. So you can always subscribe. I request all students to subscribe that. And I hope this lecture may be useful, especially for students. Again, I thank Professor Manoj for having invited me and given opportunity to the entire faculty. Thank you very much.